Hello and welcome to this fourth year dermatology lecture. My name is Eliza and I'm one of the foundation doctors at Sandwell Hospital. Today we will focus on dermatological emergencies. By the end of this session you should be able to describe the typical clinical features and explain the underlying causes and initial management of the following dermatological emergencies: acute urticaria and angioedema, acute meningococcemia, Stevens-Johnson syndrome and toxic epidermal necrolysis, erythroderma, eczema herpeticum and necrotizing fasciitis. Dermatology might be the last specialty that springs to mind when you think about emergencies in medicine. However, there are a number of rare but potentially fatal conditions that you will need to be aware of for your exams and as a doctor. The conditions we will cover are listed here. We will look at each of them in turn. Urticaria is commonly known as hives. It is caused by the activation of mast cells in the skin, which release inflammatory mediators such as histamine, causing capillary leakage and vasodilation. This leads to swelling of the superficial dermis, causing wheals. Wheals are central swellings, usually red or white, surrounded by an erythematous flare or area of redness. They may be itchy and are usually transient, lasting less than 24 hours. Urticaria may be acute or chronic depending on the duration, but we will focus on acute urticaria today. There are various triggers including food, drugs, insect bites, or contact allergens such as latex. Management involves avoiding the trigger and giving a non-sedating antihistamine. If symptoms are severe, give a short dose of oral steroid. Urticaria may also be associated with angioedema and anaphylaxis, which can be much more serious conditions. Angioedema is caused by deeper swelling in the dermis and subcutaneous or submucosal tissues. It usually affects the skin and the mucosa of the face, genitals, hands and feet, and is not normally itchy unless associated with an urticarial rash. Management of angioedema involves antihistamines and steroids, which may be given intravenously if it is rapidly developing. Anaphylaxis is a life-threatening systemic allergic reaction with rapid airway, breathing or circulation problems. It may be preceded by urticaria or angioedema. Anaphylaxis is a medical emergency and treatment involves rapid administration of intramuscular adrenaline, intravenous antihistamine and intravenous steroids. Acute meningococcemia is another dermatological emergency. Neisseria meningitidis is a gram-negative diplococcus spread by droplets. It may cause meningitis, which is inflammation of the meninges around the brain and spinal cord, or meningococcemia, which is infection of the bloodstream. An infected individual may suffer from one or both of these conditions. Meningococcemia causes a meningococcal rash. It is classically a non-blanching petechial rash which develops because bacterial toxins damage blood vessels to cause leakage. The rash may progress, leading to larger bruising or ecchymoses and tissue necrosis. Intravenous antibiotics must be administered as soon as possible. Complications can be severe, including septic shock, DIC, multi-organ failure and death. Stevens-Johnson syndrome and toxic epidermal necrolysis are variants of the same condition. They are rare, severe, potentially life-threatening skin reactions characterised by sheet-like skin and mucosal loss. SJS and TEN are differentiated by the degree of skin and mucous membrane involvement. SJS is defined as skin detachment of less than 10% of the total body surface area. SJS-TEN overlap is 10 to 30%, and 10 is more than 30%. 75% of cases are caused by drugs, and examples are in the blue box on the right-hand side. Other causes of SJS and TEN include infection, vaccinations and cancer, and sometimes no cause is found. The rash tends to appear within a few days to 1 month after the drug is given. The mechanism of action is not fully understood, but it's thought to be a T-cell mediated reaction to toxic drug metabolites. Before the rash appears, There is usually a prodromal flu-like illness, such as a sore throat, myalgia, and fever. The rash appears suddenly after 3 to 4 days. It begins as tender erythema with red macules or target lesions, then develops into blisters and erosions which coalesce to cause sheet-like skin and mucosal detachment. Nikolsky's sign may be positive. This is when rubbing the skin causes blisters and erosions to appear. SJS and 10 affects the skin and the mucosa, so it may involve the eyes, mouth, pharynx, upper respiratory tract, gastrointestinal tract, urinary tract, and genitals. This acute phase lasts 1 to 2 weeks. In terms of diagnosis, it is a clinical diagnosis. Bloods can assess the severity of the disease, and a skin biopsy is also helpful, showing full thickness epidermal necrosis. In terms of management of SJS and 10, you need to stop the causative drug. Patients usually go to intensive care or a burns unit for supportive measures such as fluid replacement, analgesia, temperature maintenance, and skin, eye and mouth care. Management is multidisciplinary, involving specialties such as dermatology, ophthalmology, and respiratory, depending on the body systems involved. Drug treatment is controversial, but sometimes steroids, intravenous immunoglobulin, and plasmapheresis are used. In terms of complications, the skin normally acts as a protective barrier, so extensive skin damage can lead to dehydration and infection. Serious complications include sepsis, shock, and multi-organ failure. The mortality rate is 10% for SJS and 30% for 10. Re-epithelialization takes several weeks, and 50% of surviving patients have long-term sequelae involving the skin and mucous membranes, such as scarring. Erythema multiforme was previously considered to be a mild form of Stevens-Johnson syndrome, which is why I'm mentioning it in this lecture. However, it is now recognised as a distinct disorder. It is a hypersensitivity reaction, and 90% of cases are triggered by infection. The single most common trigger is herpes simplex virus infection, usually a cold sore. Rarely, medications can also trigger erythema multiforme. It is most common in young adults and is usually acute and self-limiting. It is characterised by target lesions, which begin on the hands and feet and then spread across the body. Target lesions consist of 3 concentric colour zones. The centre is dark red and may form a blister. The middle ring is pale pink and the outermost ring is bright red. The target lesions can be different shapes and sizes, hence the Latin name multiforme. There may be a mild itch or burn associated with the rash, but patients are usually well. Erythema multiforme is classified as minor or major, depending on whether or not there is mucosal involvement, usually in the mouth, causing blisters and ulcers. Usually no treatment is required and the rash settles over a few weeks with no complications. Erythroderma literally means red skin. It is also called exfoliative dermatitis. More than 90% of the skin surface becomes red, warm, edematous and peeling. It may be itchy. Patients are usually systemically unwell with malaise and lymphadenopathy. Erythroderma is usually caused by pre-existing eczema or psoriasis, especially after the rapid withdrawal of steroids. But other causes include lymphoma, leukemia, drugs, and 30% of cases are idiopathic. Erythroderma is 3 times more common in men than women. In terms of management, emollients and wet wraps can be used to maintain skin moisture, and topical steroids may help to relieve inflammation. In terms of complications, patients may develop secondary skin infection, fluid loss causing dehydration, heat loss causing hypothermia, and cardiac failure. Mortality rate is 20 to 40%. Eczema hepaticum is a rare but serious skin infection. It usually affects children with atopic eczema. Most cases are caused by herpes simplex virus 1 and 2, the same virus that causes a cold sore. The rash appears 5 to 12 days after contact with an infected individual. It causes clusters of itchy, painful vesicles and punched out erosions, usually on the face, but it can spread throughout the body. Patients are usually systemically unwell with fever and lymphadenopathy. There may be secondary bacterial infection causing impetigo and cellulitis. Rarely it can have serious complications such as herpetic keratitis of the eye and encephalitis. Eczema hepaticum is usually diagnosed with a viral swab from the base of the blisters. It's treated with oral or intravenous acyclovir and antibiotics if there is a secondary bacterial infection. Necrotizing fasciitis is colloquially known as flesh-eating disease. It is a rare but life-threatening infection of the subcutaneous tissue and fascia of the skin with secondary tissue necrosis. It is usually caused by group A streptococcus. It can affect any part of the body, but usually affects the perineum, extremities, and the trunk. Risk factors include skin injury and underlying comorbidities such as diabetes or alcohol abuse. In terms of presentation, in the early phase there are only minor skin changes, such as erythema and swelling. Important early clues are severe pain and systemic illness out of proportion to the physical skin findings. Over the next few days, blisters form, then the skin turns dusky as it necroses, and crepitus may develop due to subcutaneous gas. It is a clinical diagnosis. Treatment is urgent surgical debridement to remove the affected tissue and IV antibiotics. If there is significant skin loss, skin grafting and in some cases amputation is required. Even with surgery, mortality rate is 20 to 40%. So the key points to take away from this lecture are that dermatology can have emergencies. Always take a thorough drug history because often drugs are the underlying trigger. Conditions such as TEN and necrotizing fasciitis can have fatal outcomes. And management is often multidisciplinary as multiple body systems may be involved. Thank you so much for listening, and I hope you found this lecture useful. If you have any questions, feel free to email me on the address provided.